Okay. So we're actually going to address issues pertaining to menorrhagia and adolescence today. I think that the easiest thing would be if Leo agrees to take questions at the end. I'll leave sufficient time. Of course, in terms of medical relevant disclosures, I have none that are relevant to the talk, but I do have some other non-medical disclosures for this talk today. First and foremost, I'm in a busy clinic today. It might not appear that way. Two, the test run didn't really work out that well when Leo and I tried last week, and he almost set me up to present at another hospital at the Children's, which is about 30 minutes from here, while I'm in a busy clinic. And this is also the second slide set that I've made in this last 48 hours. You might want to know why, but I tell you that my Windows completely corrupted 2 days ago, and so this is the second slide set from scratch. I hope, though, despite those difficulties, that I'm going to make you understand the pathophysiology and epidemiology of adolescent menorrhagia, that we're going to review together the hemostatic the anomalies or the abnormalities associated with adolescent menorrhagia, familiarize ourselves with the current trends, and of course highlight important challenges faced in the management of young women with bleeding, certainly in menorrhagia. Adolescence is a time of turmoil, I might say, and I hope that picture represents it well. Issues about self-identity emerge, issues about role confusion. It's a turbulent time at best, and of course with the added possibility of having heavy menstrual periods doesn't make that time much easier. What's the definition? We're going to start off with a few basic definitions so that we can follow the rest of the talk. And the first thing I'm going to define is adolescence. I remember people asking me this very often, and it's not exactly the same as the definition of being a teenager, because it actually starts with a physical and psychological development that generally occurs from the time of puberty and ends in adulthood. But of course, puberty now, more often than not, starts before teenage years, and so they're not synonymous. And in Latin, what it means is to grow up. And the cartoon might not project very well, and it's in French, but what it shows is a young girl or adolescent sitting at the side of the street, looking confused, looking in turmoil, and the street sign above her pointing in two different directions indicates, in French, childhood one way and adulthood in the other way. So it's a very difficult time, and it poses specific challenges to the treating physician dealing with menorrhagia. The second definition that I want to discuss is the definition of menorrhagia itself. And many of you are already familiar with these definitions, but I'll repeat it for clarity, that refers to prolonged more than 7 days of bleeding, or excessive, if you can measure it in some way, directly or indirectly, more than 80 milliliters of blood loss per cycle, but bleeding that occurs at regular intervals, and that's the important part. A normal menstrual cycle, therefore, should be less than 7 days, should recur every 21 to 45 days apart, and what's considered normal is changing pads 3 to 6 times a day and not more. I'm going to define another term that you see in the literature, and it brings confusion. It's called heavy menstrual bleeding, and you've seen the term HMB abbreviated many times in the literature. What this refers to is heavy uterine bleeding in the form of menses, but regardless of the pattern of the menstrual cycles. So in other words, even irregular cycles are included in here. And it might be a more appropriate term to use when we're dealing with adolescents, certainly at the time of menarche, to define the issues that we're presented with. We also know that menstrual cycles are often irregular in young adolescent girls because of frequent anovulatory cycles. And I think that the term heavy menstrual bleeding is probably more appropriate when we're dealing with adolescents. Heavy menstrual bleeding, and just to mention, those terms will be used on occasion synonymously for the purpose of the talk, only because the literature reflects the confusion, and so some studies refer to menorrhagia and others heavy menstrual bleeding. But even in the studies that refer to menorrhagia, very often you'll see irregular cycles mentioned in the text. In terms of the prevalence, what's the nature of the problem? How big of a problem is it in adolescence? And what I've put together here is a table looking at prevalence rates of adolescents with heavy menstrual bleeding from different countries. And most of the time we quote North America and the United Kingdom, 30% prevalence rate. But if you look down the list, you'll see in countries like Nigeria, Hong Kong, and Sweden, you have prevalence rates ranging from 12 to almost 40%. So this is a very significant problem, and as hematologists, we're often referred patients, sometimes first line, and we sometimes have to know how to deal with it. What's the impact in terms of school performance and social activities? When I first heard about this, people said, well, you know, maybe we're making a big deal of nothing, this is a variant of normal. But the fact is that if you look at the data, and this is not referring to bleeding disorders, these are adolescents with heavy uterine bleeding. If you look, 12% of girls have adverse effect on their school performance. Can you hear me still? There's a lot of static. Leo, can you still hear me? Yeah? Okay. 12% had adverse effect on their school performance. Almost a third missed lectures and had exam marks what they judged as adversely affected by their bleeding. And there was a direct correlation in these questionnaires with greater levels of blood loss and, of course, the dysmenorrhea that comes along with heavy blood loss. There was a significant rate of absenteeism.
I went through this a couple weeks ago, and they were supposed to have the right one now.
where girls often had missed school because of heavy periods, and 50% had limitation in sports activity and social activity. So this is quite a very important point, and we don't talk about as much in the adult literature as we do in the adolescents. What's the impact on hospitalization and medical interventions? Equally as impressive. We know that adolescents often require hospitalization within the first year of menarche. I don't know how often is. We don't have exact numbers, but we know that young girls are often in the hospital for heavy periods, especially in the first year. In one particular study by the group in the United Kingdom working out of the Royal Free, we can see that 12% of girls in the age range of 12 to 19 years with inherited bleeding disorders in that case required hospitalization. We don't have numbers for the girls without bleeding disorders. And up to 12% required medical interventions. So this is quite a significant problem. Looking again at other significant problems, the impact on anemia. I didn't include this in the slide, but it's well known that iron deficiency anemia, and studied actually in healthy female soldiers, where most of the data comes from, shows aberrant mentation, difficulty concentration, and decreased work performance. Now, these are in military soldiers, but in any case, one would have thought that iron deficiency anemia would have as great as an impact on school performance and other performance in young girls. And so one of the myths we're going to demystify is that I'm not sure that iron deficiency impacts, at least proven impacts on it. However, we know that about 9% of adolescents with menorrhagia and 9% of adults with bleeding disorders and menorrhagia will have anemia, so almost 10%. We know that women with anemia, because of heavy menstrual bleeding, are more likely to be seen in the emergency room, have blood transfusion, and certainly related to higher hospital costs. We also know that they get transfused more often, young girls, when they go to the hospital, with a 44% incidence of transfusion with hemoglobins less than 100. That data, though, is a little bit tarnished by the fact that it was published a very long time ago. On the one hand, you might say that blood products are now more safe and that the threshold for transfusion is probably a little bit lower now than it used to be. But on the other hand, we didn't have in wide use modalities such as tranexamic acid at that time. So hopefully the two balance out, but the numbers are pretty scary, that 44% of girls admitted to hospital receive transfusions. We know that menorrhagia affects quality of life. It's been studied in two very well done studies, both in adults and adolescents. So we know that if you look at quality of life scores in a more formal matter, we know that the quality of life in adolescence is actually inversely related to the blood loss, and that particular study looking at the use of the pictogram or the PBAC score. Just looking at the specific issue of iron deficiency, in one study it was shown that fatigue severity score was higher in adolescent girls with heavy menstrual bleeding, but there was actually no direct relationship that was able to be teased out in relevance to the... In terms of anovulatory cycles, it's important to understand that normally the endometrium undergoes regular shedding with ovulation. However, due to immature hypothalamic pituitary axis in adolescence, there's actually a delay in the production of progesterone that lags behind the development of normal estrogen, which means that many of the cycles are anovulatory. And what happens is that you have a progressive accumulation of endometrial thickness, which leads then to irregular shedding, and very clearly leads to sometimes increased blood loss, but also unregulated bleeding, so menorrhagia. People often ask how often that's going to go back into order and how often it's going to take care of itself. And the answer is most of the time, but it might take some time. So if you look in adolescence at the time of menarche, up to 85% of all cycles are anovulatory. And by 4 years, still 56% are still ovulatory, which means that 44% are anovulatory at 4 years. So the main thing that you could say to the patients is that by 5 years, anovulatory cycles should stop, unless there's another medical problem underlying it. What's clear in the literature is that girls that have earlier menarche have faster normalization of ovulation. What's important to remember in adolescence, and sometimes when we're not the first line, usually it's the gynecologist, the pediatrician, or the pediatric gynecologist that would look into this normally at first. But to remember always that there's other underlying cause other than bleeding disorders, of course, and in particular endocrine. You never should forget pregnancy, and then other uterine issues like polyps, cancers, sometimes medications, and of course trauma. So these are other considerations that we can't forget. In particular, most cases of abnormal bleeding in the adolescent are due to anovulatory bleeding, either alone or in combination with a bleeding disorder. So the focus of what a hematologist does on a daily basis is that we're actually there to exclude the minority of patients that have an underlying bleeding disorder, probably thinking with the idea that we can serve them better and offer a different gamut of treatments, even though the baseline treatments don't vary all that much, as we'll see. The prevalence of bleeding disorders in adolescents with menorrhagia is really variable, and if you look across the literature, you're going to see numbers ranging from 7 to 48%. And you might ask why. Well, there's a whole bunch of reasons. Some of the studies have been taken, have looked at prevalence rates in hospitalized patients, others in outpatient clinic. It also matters which clinic. Is it a tertiary care referral center, a hemophilia treatment center, or is it a gynecology clinic? And also there's enormous variations in hemostatic testing. If you send a von Willebrand from another hospital and it takes days to be analyzed, or if platelet functions are being done, and how a platelet dysfunction is going to be diagnosed. Is it with one agonist that they're not reacting to, or is it many? So definitions vary, and hospital patient settings vary enough, and I think that's enough to explain why the range varies so much. What this slide shows is a combination of all those studies that I just referred to, looking specifically at prevalence of von Willebrand disease. And if you take a look at the list, you're going to see that the numbers start as high as 36%, and you can see that these patients were seen in an outpatient hematology clinic, so a tertiary care center, and there might be some referral bias. As well here, hemophilia treatment center in the United Kingdom. So those numbers are particularly high, again, maybe because of referral bias, whereas all the other numbers are much lower. This is a similar slide looking at many of the same studies as in the previous, but this time looking at the issue of von Willebrand disease, but also other bleeding disorders. The numbers we just saw in von Willebrand disease are here, but what I want to draw your attention to here is the platelet dysfunction number that shows up in the Phillips study in 2005. There have been studies lately that show that platelet dysfunction may be as frequent as von Willebrand disease in adolescents or even women presenting with bleeding disorders. We don't know yet, but it certainly begs the question to know whether we should be testing platelet dysfunction up front or not. I do want to caution you that in that study by Phillips, they treated aggregation defects to one single agonist as a platelet dysfunction, and that was present in about 30% of all patients. So the definition might have been a little bit loose. We typically consider 2 agonists or more. But in any case, I think definitions vary, and it might be one explanation as to why platelet dysfunction was so common. In some of the other studies where it's slower, I don't see any of them listed here, but there are some from the United Kingdom, and there, for example, they don't test platelet function in everybody up front. And then, of course, other factor deficiencies are less common. What is the chance that we find an underlying bleeding disorder? If we test girls with heavy menstrual blood loss associated with the Menorrhagia, the Menorrhagia actually comes out as a significant variable. We have 50% chance of finding an underlying bleeding disorder. If the girl requires blood transfusion, the data shows that you should be able to find, and this is from the Klassen study, 30% of bleeding disorders. 25% of hemoglobin is less than 100. So this is a marker for me of severity. If it's present from the Menorrhagia and if the girl requires hospitalization, your chances of finding a hemostatic defect go up. And that might be a sufficient argument to test these girls up front. When you look at what's being done, are girls being tested? You can see that about a third of physicians ask screening questions for a bleeding disorder in adolescents with Menorrhagia. And of course, the numbers vary a little bit depending on who's doing asking the questions. It seems to be that gynecologists, the general gynecologists, are doing the best at it, whereas the pediatric gynecologists are not doing as well. Now, these numbers date to 2008, and hopefully with efforts to increase testing, those numbers will improve. Only 14%, though, of all of these patients were screened for a bleeding disorder using laboratory testing. So there's a lot of work to do still there. This is just giving an idea what's happening in the literature. There's been a boom in publications looking at menorrhagia and bleeding disorders. It's continuing on the rise. This last data dates from 2011, but we can only imagine that there are increased numbers of publications in this area. And so I'm sure that we'll have more information soon. People often ask, what's the age of diagnosis of bleeding disorders? And if you look at this particular study, and I'll point to the part of the graphic that's the most important, it seems that the age of diagnosis is younger. So it suggests, at least if you look at it quickly, that the chances of having a bleeding disorder are greater when you're younger than when you're older. But in fact, it's more likely an issue of again, selection bias, where physicians in general, and this has been looked at in the literature, are more apt to test a younger person for a bleeding disorder presenting with menorrhagia than an older person. And that is then actually showed by Philip et al. In 2005, who looked at bleeding disorders that you see here on the left, and looked at different age groups, less than 19, 20 to 44, and greater than 45, and showed quite clearly that the chances of having a bleeding disorder are probably equivalent at every age group. So it's just that we tend to do a little bit more screening in younger age, and so it appears that. But if you look at perimenopausal women, it seems that they have as unequal chance of being diagnosed with a bleeding disorder. Those statistics should change because we should be, with the efforts and national efforts, trying to diagnose earlier. Hopefully these numbers will change. In terms of the bleeding history, what's helpful to guide us as to when to look for a bleeding disorder? We know from the Italian group that bleeding, cuts and wounds, tooth extraction, and postoperative bleeding are very clearly correlated with an increased chance of finding an underlying bleeding disorder in young girls presenting with menorrhagia and other bleeding. What also came through more recently in 2005 also is that positive family history of bleeding was a very, very strong predictor of finding an underlying bleeding disorder. And of course, from the older literature, but also a newer publication in 2010, that it seems that the heavy bleeding that's present from the beginning, heavy menstrual bleeding, even during the time of anovulatory cycles, is also a factor that's predictive of finding a bleeding disorder. I'm not going to discuss in detail bleeding assessment tools because there's, I think, people that are more expert than I am in this area, certainly in Canada, and our colleagues in Kingston. But suffice it to say that bleeding assessment tools are on the horizon and are being developed at a very rapid pace to help clinicians decide and triage young girls with heavy menstrual bleeding to decide who requires and who does not require hemostatic testing. The set of bleeding scores, the gold standard, it's a very long bleeding score that's been modified in a condensed version by the group in Kingston, and there's been applications to pediatrics. As far as I know, there have not been any validation studies that have been published thus far, maybe ongoing, in adolescents with menorrhagia. They can be helpful, though, to guide us in terms of having a big picture of the bleeding in that person. It's a little bit less helpful when it's addressing a group of girls that have isolated menorrhagia. There is one screening test that was published in 2011 by Claire Phillips. The initial publication is a few years before that. But she published an 8-question screening questionnaire looking at 4 categories, which include duration of menses, history of treatment for anemia, family history of a diagnosed bleeding disorder, and history of bleeding after surgical interventions or tooth extractions. And what it shows is that if you apply the bleeding questionnaire, that you have a sensitivity of 89% for hemostatic defects. And then if you add to that iron deficiency, it increases to 93, and if you add to that a PBAC score of more than 185, you end up with a sensitivity as a screening tool of 95% for bleeding disorders in women with menorrhagia. Now, of course, this is not applied to adolescent population, but in general, I think it's recommended by most of us to at least use it as a guide to help decide for the moment whether we should go on to hemostatic testing or not. Turning now to menstrual blood loss measures. I think that as clinicians, we often want to get the answer just by asking questions. And I think most often we're actually fairly good at it. We know that of subjective reports of girls complaining of menorrhagia, only 30% will have objective criteria of menorrhagia. But when the physicians are asking the questions, we tend to have very good reproducibility. It's not perfect, though. And what comes through in the history is changing pads less than every hour, passage of big clots, soaking through night clothes, and low ferritin could be indices of finding an underlying bleeding disorder. And the American College of Obstetrics and Gynecology has shown some of those criteria to hold true as well. We're dealing with adolescents. So the other way to objectify blood loss, of course, is to look at pad and tampon collection. And I put the answer of the adolescents in brackets. That's the answer I get in clinic if I even dare mention that. No way. There are some data showing that weighing pads might be very useful, but again, who's weighing the pad? Do they have to bring them in, or are they doing it at home? And I think many of you are familiar with the Diva Cup. Is there anybody in any of the centers that has not heard of the Diva Cup? No. So the Diva Cup is a silicone cup that's inserted into the vagina that actually collects blood, and it's a direct measure of blood loss. And so it's very popular in some of the provinces. In Quebec, it has not caught on very much. But what's very interesting about it is that girls that try it tend to stick with it because it actually leaks less and it doesn't have to be changed very often. So it's very helpful for school. The gold, the practical, I would say, gold standard is the PBAC score, the semi-objective tool that many of you have seen. It's depicted here on the right in its original format. What it shows is pads and tampons with different degrees of blood staining on it. And the person that is measuring her periods would then make a mark every time she changed her pad, tampon, or both on that particular day, with the days being across the top, day 1 to 8. And using this score calculated by initially the gynecologist, but could be extrapolated to the physician, there's an 89% and 86% sensitivity and specificity in adults. The numbers have been reproduced just one time in pediatrics that I know of in Nigerian girls. And shows a little less, but sensitivity of 80% and 75 specificity. The other point is, the question is, how often does it correlate with what the adolescent thought she was bleeding? And if you actually look, you would see that of the adolescents that report that they say that I'm bleeding a lot, only 50%, so a little more than half, have PBAC scores of more than 100. And a little bit on the opposite spectrum, some of the girls that said that they were bleeding very little, 12% had PBAC scores of 100, more than 100. So, you know, the history doesn't correlate 100%, but we feel that the PBAC score is probably the most useful scoring system for adolescents at this time, unless they're willing to try the Diva Cup. I think a really important issue is treatment endpoints. We typically talk about blood loss in adults, and there's been studies and current opinions published on this issue about what's a meaningful reduction. The number that comes through is 36 milliliters per cycle, keeping in mind that more than 80 milliliters per cycle represents menorrhagia. But I'm not sure that the number is probably what's most important, at least in my experience and from what I can retain in the literature. It seems that probably we should be focusing on all the issues that I've mentioned so far: quality of life, anemia, long-term outcomes, meaning including fertility, and probably should focus on patients' perceptions. In a particular study looking at that, women in general, whether the menorrhagia was proven and whether the menorrhagia went away alone or with medical intervention, it seems that if you pay attention to it, people are satisfied. And that was a questionnaire done in 1995. And I think that it's very clear that, more of the literature looking mostly in carriers of hemophilia, but other young girls with bleeding disorders, these patients require really psychological support, and a sound psychological status should be a very important treatment endpoint. Some of the challenges that you all know about are the fact that there are special considerations when you evaluate these young girls. One is that a pelvic exam is not done routinely like it would be in an adult. And so imaging takes a higher priority, ultrasound and sometimes MRI. And we can't forget to do a pregnancy test, even if we're seeing them on second line, because actually the new numbers, well, at least from 2010, show that 62% of teens are sexually active by grade 12. So the first sign of a lost pregnancy or miscarriage could be heavy bleeding. And of course, always keep in mind that we should be sensitive to issues about sexual abuse. What's the laboratory testing that's recommended in adolescents with menorrhagia? I think I want to keep it simple and just say that a complete blood count, making sure that we don't have a platelet thrombocytopenia, coag studies, fibrinogen, and a von Willebrand profile. Many people ask, and very often so, is it worth doing a von Willebrand profile up front? And my answer is consistently yes, for a whole bunch of reasons. One is that it helps with the treatment options that we can offer. And plus, once you miss that occasion at first to do von Willebrand testing, you might have lost the occasion for years. Between treatments with hormone agents, pregnancies, you may end up going years and years without a diagnosis. And then you get into the whole issue about labeling somebody with a potential diagnosis that they might not have. And to further support that, there was a study in 2011 that showed that it's actually cost effective. They looked at girls that were tested versus girls that were not tested, where the diagnosis was in limbo, and you can see very clearly that there's a cost benefit even to doing it up front. I think the issue is when to do it, and I don't think the girl that comes in major hemorrhage who has a physiologic stress is the time to do it, but I think certainly in the first few visits it should be done. Again, because the literature suggests that platelet function might be as common as von Willebrand disease, you might consider doing it fairly early if the von Willebrand screening is normal. And I would have to discourage, especially in the acute setting, to do PFA testing. And as many of you might know, I'm a big advocate of the PFA. We use it here, but in a status quo setting. So once the girl has been treated, the anemia is resolved. The problem you get is that when the patient is too anemic, the PFA is always long. And we know from some studies that it might miss some of the milder von Willebrand deficiencies, in whom the knowledge of the low von Willebrand level may have altered your therapeutic choices.
Yeah.
We all know the variables affecting measurements. I just want to point out, like again, the dilemma is always trying to get the testing done before hormones are started. It's not always possible, and I don't have a graphic to show you here, but suffice it to say that the recent literature and the current literature does not appear that the low-dose estrogen pills affect von Willebrand levels. And so you can be fairly sure, in the absence of a major history with isolated menorrhagia, in a young girl on a low estrogen dose pill, that if you have one good analysis done out of the situation of a major emergency, that you can be fairly confident that you haven't missed anything, at least in von Willebrand. It might entice you to go on. In the high-dose estrogen scenario, I would encourage you to retest at a later time, keeping in mind that we never stop the pill when it's being used to control for menorrhagia for the purposes of testing. There's a paucity of studies looking at specifically at adolescents, little consensus in treatment. There are few dose comparisons in the different drugs that are used. But I think that the main choices when you're faced with an adolescent in clinic is to consider the issues related to compliance. Is the pill have to be taken every day, once a week, just during my period, or never? Consider the side effect profile, especially for our gynecology colleagues looking at the acne and weight gain. Addressing issues, the need for contraception, and should take into consideration certainly cultural issues, which play a big role in some of the choices. In the next few slides, I'm going to show you I'm going to go treatment by treatment, but I'm really going to focus on two issues that are emerging in adolescent care in menorrhagia, specifically the use of the contraceptive pill and the Mirena device. This is an excerpt from an international consensus conference that was published looking at an algorithm used in adults to treat menorrhagia. And it starts off asking, would the patient like to preserve fertility? Of course, this is not relevant to the adolescent because the answer is yes, so we're automatically on the left side of the graphic. Would the patient like to become pregnant now? I think it matters who you ask. If the mother's sitting there, you don't want to ask it like that. And I think the bigger question for us is the patient sexually active, because that will make a difference as to whether we push more of the hormonal therapies versus the others. So this algorithm for me is not really all that relevant for adolescents, and I think we need to work on a new one. If you look at treatment practices, what's being prescribed? If you look at adults, it's mostly the contraceptive pill.
Dr. Alan Thompson in gastroenterology.
If you look at the adolescents with inherited bleeding disorders, now of course this is a study in inherited bleeding disorders, but nonetheless it's the only study we have, and coming from the UK, it seems that they're more often prescribing tranexamic acid as first-line solo therapy. Sorry, I just want to mention, so the reason that the UK might be using a little bit more tranexamic acid than the pill is, for one, because they have a lot of issues, from what I'm told from colleagues, with parents intervening and not wanting their children to use contraceptive methods, partly out of fear that it might entice sexual and precocious sexual activity. Also, with adolescents, they tend not to be compliant on the whole. Tranexamic acid only has to be taken during their periods, as opposed to the pill, which has to be taken every day. So these are considerations that might explain why in adolescents we're using a little bit more tranexamic acid than the pill, even though what's recommended in all the guidelines across the country and across the world even suggest that contraceptives should be the first-line therapy. It also helps, the pill as first-line therapy helps cycle regulation, it improves dysmenorrhea, and it certainly helps PMS symptoms. So those are some of the advantages. My colleagues in gynecology tell me that all the pills are pretty much similar in terms of their contraceptive efficacy, but of course we choose them based on side effect profiles. And the way they work is, one mechanism is just that they prevent ovulatory bleeding and increase von Willebrand and factor VIII. And that second mechanism might be a little bit more important in the acute setting than it is in the long term. So this we discussed a little bit about already. The issues I want to bring up about the pill is that what's very popular now is not just treating with the pill, but treating with extended or continuous use, 3 months or more. It's the method preferred by most adolescents because they have no bleeding for 3 months at a time, so it interferes less with all those social activities and school that we discussed at the beginning. And there's actually been 6 randomized control studies looking at continuous versus cyclic and showing a greater satisfaction and showing its safety to continue for long periods. The Mirena device, most of you are familiar with. I won't go into detail about the actual device. Suffice it to say that the American College of Obstetrics and Gynecology supports its use and its safety. And it's been shown to be efficacious in women with and without bleeding disorders. What's really important, and one of the studies that came out of Kingston shows that if you that there's a high expulsion rate in women with bleeding disorders, and probably the reason that we're not seeing this at our hospital is all the women that have hemostatic abnormalities and the young girls that are receiving the Mirena device are treated with hemostatic therapy up front. Why isn't it used? Probably because of the reputation of the older copper IUDs that caused increased pelvic inflammatory disease and bleeding. The spotting can be bothersome, and in nulliparous girls, it has to be inserted under general anesthesia. In adolescence in New Zealand, the 1-year continuation rate was 85% and a cumulative expulsion rate of 8%, which is similar to in adults. And a very small series in adolescents showing that, in general, when it's used for heavy menstrual bleeding, it's quite satisfactory to them. This is what the graph looks like in the experience of adolescents, in the 5 adolescents using the Mirena device. Pre-insertion, what you see is that these are PBAC scores on the left, and these are PBAC scores listed pre-insertion and then at the time of follow-up. And you can see that there's actually a significant decrease in the PBAC scores. So it looks like it's a very good alternative. People are reluctant to use it in young women. At St. Justine, we tend to use it quite often, actually, in teenagers and young girls, even before they're sexually active. In this particular cohort that was published in 2010, what you see is that in a group of adolescent girls, it was used mostly, and I'll draw your attention here, as a contraceptive method, but in 35% to treat menorrhagia. Most of those girls had failed previous therapies, so they had tried the pill, they had tried Depo-Provera and it didn't work. One had failed tranexamic acid, but there was an issue, a social issue that required better control for menorrhagia. And most of these were inserted under general anesthesia at our center. And what I'll show you is that what's actually a little worrisome is that even though at our center the follow-up rates at 1 year were as high as they were reported in the previous study I showed you, by 2 years it falls off dramatically to 45% that keep their Mirena device. We don't really know why that is. It could be that once the bleeding slows down, they become less tolerant, and we know that it can cause an exaggerated pain in young girls with a small uterus. My colleagues tell me in gynecology that a new Mirena device is on the horizon that's very small, that might help us with the long-term use of the IUD in young girls. There are other hormonal therapies. We use them less, but usually in patients that are refractory, so cyclic treatment with progesterone, and many of you know Depo-Provera intramuscular. It's very good for compliance. It only needs to be given once every 3 months, and there's a new subcutaneous form that's available now for girls that are very worried about intramuscular, and where we're particularly worried about intramuscular is especially in the young girls with bleeding disorders. So the subcutaneous variant is going to be more widely used, I would suspect. The last slide, or the last couple of slides, just on treatment, tranexamic acid. There's no studies exclusively in adolescents. Busy slide, just showing you that it's actually very effective, and girls like it because they only have to take it during their periods. My colleagues in Halifax hopefully will tell me soon whether we could start at a lower dose and still be effective. The side effects are mostly gastrointestinal in nature. They're dose dependent, so if you decrease the dose, they go away. And most of our young ladies that are taking it are very satisfied. There seems to be no clearly demonstrated thrombosis risk. I'm very well aware that there are case reports, but in the biggest study that was shown, the odds ratio was 3.2, but with a confidence interval that was not significant. I say not significant, but if you look at the upper range, you may agree with me that this deserves further study because the confidence interval goes up to all the way to 16. But for now, I don't think that we can say that there's a clear increase in thrombosis risk. You would want to avoid it, though, in girls that have a predisposition or heavy predisposition to thrombosis. DDAVP, there's no studies in adolescents. It's been looked at in children. Children respond well. When it's combined with cyclocapron, it's more effective. And it's been shown to be useful not in bleeding disorders, but in adolescents that have a prolonged bleeding time without a diagnosis. We can't forget, though, that when all else fails and we're trying to avoid surgery, if we have a bleeding disorder demonstrated, you might consider that using a specific factor replacement, either on an as-needed basis or in prophylaxis. And this is at least a strategy that's used in von Willebrand patients who are refractory to other treatments and who wish not to opt for surgery. How are we doing with all those treatments? This is a study showing you, the first graphic up here on the left shows pBAC scores before and after treatment. These look at all treatments, so combined treatments for adolescent menorrhagia. The pBAC score significantly decreases during treatment, regardless of which treatment we're using. If you look at hemoglobin and ferritin, we're doing pretty well. Pre-treatment hemoglobin, post-treatment hemoglobin is higher than the pre-treatment, and this was significant, as was the serum ferritin, which got higher after treatment. So overall, in terms of blood loss, we're doing quite well, no matter what we're using. Other things you might consider is anti-inflammatories in girls that don't have bleeding disorders. There's evidence, a huge Cochrane review that was just republished and refurbished in 2013. Other GnRH analogs, danazol, very little use because the side effect profile is very heavy. And in a recent case we had here, we resorted to urgent embolization in a child that was refractory. If you do have embolization available to you either in your center or in a nearby center, it's important to discuss with the radiologist, the interventional radiologist, and ask them if it's possible to use the least toxic sclerotic agent, because some of them are actually reversible and will have less of an impact on future infertility. Surgical treatments, I can just summarize in saying that we should not use them, except for, of course, a curettage in the case of a miscarriage. And even though endometrial ablation is used successfully in adults, we should avoid it in children. This is the trends in hysterectomy for menorrhagia in all women. I hope the slope is steeper for adolescents. We should not be doing hysterectomies in adolescents with the armamentarium of choices we have these days. It's clear to me, and as you know, I'm a big advocate of multidisciplinary approach. It's important because of the social and the psychological impact. And it's very clear, and the guidelines suggest very clearly that adolescent girls with menorrhagia should be treated in a multidisciplinary team. Acute menorrhagia is a particular challenge. When I say acute, it's the ones that bleed enough that you contemplate hospitalization. There's no evidence of any specific treatment except to say that high-dose estrogens, particularly Premarin, is probably the most widely used, but also very successful in stopping acute bleeding. This is just an example from the study of Wilkinson that shows an algorithm saying that you should hospitalize them, use high-dose Premarin if they're hemodynamically unstable, and if it's on the outpatient management that you can resort to the contraceptive pill. And also, the other important thing is to not forget to bridge. You start high-dose estrogens or the contraceptive pill, don't forget to do a bridge with hormones. So why do we need a hospital care plan for patients coming in? It's because adolescent menorrhagia we know is a healthcare problem. Sometimes people don't think about bleeding disorders. The management of the acute menorrhagic patient is all over the place in the literature. Antifibrinolytics are clearly underutilized, and we still know that even in adolescents that surgery and transfusion rates remain high. When you use a hospital care plan, and one of the take-home messages of today, a very important one, is that 80% of girls can have complete cessation of bleeding if you use a treatment plan, a hospital care plan. This is our St. Justine sample care plan. It's been published in an international review in 2011 as a prototype plan. It shows you the nursing orders, the liquid you want to give, the blood work, and I'll draw your attention to the fact that we recommend here von Willebrand profile. And then the medication we use is Premarin, and we give antiemetics because it can be very nauseating. What have we accomplished using it? We have managed to stop bleeding in 87%, and when we compared the population before and after the use of this protocol, we've actually increased the numbers to 100%. It's hard to believe, and maybe there's some recall bias or report bias, but we've managed to control the bleeding medically in all these patients from 2001 to 2007. We've also increased the von Willebrand testing pre-starting hormones from 40 to 80%. And we've also decreased the curettage rate. 13 patients pre-2000 had curetages and only 4 since. If we look at tranexamic acid use, you could see that it was much higher if the protocol was used than if it wasn't. Now, these protocols don't oblige the doctor to choose something or not. They can strike it out, but it seems that it was accepted in at least 2/3 to use it. And von Willebrand investigation was done in more than it was accepted by the physicians. And the last 2 or 3 slides just want to show you in terms of where we fit now with current trends in adolescent menorrhagia. This is a graphic looking at transfusion rates and curettage rates, summarizing the data from the studies in adolescent menorrhagia that are listed here. And you can see that transfusion rates are in the order of 45% still. Mind you, they're not new studies, but still they were. And curettage rates about 8%. With St. Justine, what we've managed to do here is that we've managed to decrease the curettage rate by a lot. And the transfusion rate we've done, if you look at the number, we've done a little less well. There might be 2 explanations. One is I think that the threshold for transfusion in 2008, when this was done, was largely different because of blood products being more secure. And also in this cohort in particular, there was one girl that had a very, very low threshold because she had a very complex cardiac function and problem that required transfusing at a hemoglobin of 80, whereas the other ones we were more tolerant. So there might be some bias there, but I think we've done better at decreasing surgery, not as well at decreasing transfusion. There's still a lot of work to do. So to conclude, I know we're running late because we started a little bit late, but things we're good at. We know that adolescent menorrhagia is a significant problem. We're trending towards multidisciplinary care and studying these issues around the best treatments for adolescents and the care of menorrhagia. And we're starting to decrease transfusion rates and preserving fertility and certainly decreasing surgery. What I think things we need to get better at, though, are identifying bleeding disorders more consistently among adolescents presenting with menorrhagia, and for that we require better screening tests and better BATs, or bleeding assessment tools. I think that we need to further optimize care. We need clear algorithms. We need to know what doses are best in adolescents compared to adults and which combinations work best. And I think we need to be very clear that we need to know what the best medical treatment strategy is, considering cultural issues, but also just issues around adolescence and the compliance issues and other troubling issues around the period of adolescence itself. And I hope with the national program Code Rouge that we're going to be able to accomplish some of these things. I want to give special thanks to all my colleagues that have published and have done this and who support me on a daily basis in the care of these girls. Thank you very much.
Thank you very much, Rochelle.
So we went
Maybe
a little
because
fast, but
we are...
minutes.
Yes. Can we see if there are questions going from west to east? 1 question per center. Anybody from BC? Hi, can you hear me?
Just to know we may be cut off. So you know.
Okay. Any questions from Edmonton? Or any questions from Calgary?
Try it with the mute on, maybe.
Any questions from Winnipeg?
And everyone already just bursting? Yeah. Maybe that's why he brought us the notes. I don't know.
Any questions from Hamilton?
Yeah, I think he thought as much as earlier.
No questions from
Linda?
Hamilton.
Thank you. Any questions from Kingston? Or Ottawa?
No questions. Great talk. Thanks.
Any questions from here? Any questions from Montreal Children's?
So Rochelle, you said you increased the rate of testing for von Willebrand's, but how many did you actually find? Was it a significant number? And how did that modify management?
Yeah, we don't know because we haven't looked back to see how many were diagnosed. That's the next step. I would assume that the numbers will fall fairly similar just based on my clinical feeling of having tested them in the follow-ups I do myself in clinic. I don't know the actual denominator or the numerator at this point, but I can tell you that I will probably be in the range of 20 to 30%. Which the literature ranges from 7 to 50. We're a tertiary care center, and I don't see any of them up front. They're all referred from pediatricians or pediatric gynecologists. So it would, intuitively, I would guess 20 to 30, and clinically, in my experience, that's about what I'm finding.
I think that there may be some referral bias in that we see a fair bit. This is Josie DiMaglio from the Adolescent Medicine Clinic. We see a goodly proportion of the kids who fit menorrhagia as referrals from the emergency room. And I would have to say that my sense of the number of kids, and we test most of those kids with for von Willebrand's either at the time of diagnosis or later by taking them on the pill. And I would say if we can get much closer to the 7 or 8% is perhaps lower than it is in the higher numbers. And I actually worry about over-testing.
I think we got cut off.
Yeah, I think you're going to cut off. So, ending unfortunately with some technical difficulties. I think I'm going to call it quits for this session. And thank you again, Rochelle, and all of the participants. We'll be having on the website the upcoming spring talk on new anticoagulants in children in a couple of weeks. Thank you very much for your participation.